the chat, or sorry, the Q&A function rather than the chat function. So without further ado, I'm going to hand over to Mary. So I'll just share my slides there, or Mary's slides, I should say. Okay. Okay, so go. It's a mouse there.
Well, good afternoon, everyone, and it's nice to talk to you and to see familiar faces. I suppose for quite a while now, I've had yet another little bee in my bonnet about how we actually are defined in the legislation in terms of radiotherapy and how that impacts on what we do clinically, how we work, also on the content of some of our education programs. And I think it's really time that we actually looked at this, that we looked at, well, what is radiation protection? What do we mean by it in radiotherapy? And how can we maybe begin to address the issues and see who we might consider focusing on to actually help to improve our situation? I can do it from there, can I? It's probably this one, is it? No? We're just trying to move the slides on. So, first of all, I went back to what the radiation protection legislation is. Sorry. And now this is European, but I've also talked to people in other jurisdictions, and they really encounter more or less the same problem with this general type of approach. So the legislation that defines us is the 2013-59 Euratom legislation, and that defines what what radiation protection means at a European level, and then how it's transposed locally or nationally. So it does impact then, say, your education programs, because it defines what the radiation protection content of education programs should be, which from a radiotherapy perspective is really very limited. And in addition, it forms the basis of regulatory inspection. So what the inspectors look at when they come out to do audits or to give licenses or whatever. And from a radiotherapy perspective, I've noticed more and more that all they're interested in really is the dose from imaging, because that's all that they understand under the actual legislation as it works at the minute. And if you look at those two issues together, well, what that does is it impacts directly on how we educate professionals in radiotherapy, and in turn then how our clinical practice is defined. And I think most predominantly it impacts on the radiation therapists, because radiation oncologists have a very defined curricula and it covers all aspects of clinical practice. And the radiation physicists also have a strong physics background. But for us, it leaves us in that limbo of being in these kind of joint courses that are predominantly diagnostic, with just perhaps a little bit of radiotherapy thrown in as an afterthought. And that is directly related to the application of the legislation. And why is that? It's because historically it encompasses diagnostic imaging, nuclear medicine, and radiotherapy as one single entity called medical radiology. And that defines everything that comes under that. And it doesn't reflect the difference in practice at all between the three disciplines. And for us in radiotherapy who've been involved in some of the EU projects, it becomes really clear when you try to fight the corner of what should be included for radiotherapy education or for radiotherapy practice. And what it doesn't do specifically, it doesn't look at what do we do in radiotherapy, where what we're trying to do is to give a high dose to the tumor, obviously, as we all know, and as low a dose as reasonably achievable to the OARs. And that's very clear for us. But that's not clear when you look at the legislation, which is very much, I think, single dose focused. And what we're looking at too in radiotherapy is effectively in the future, when it's individualized, is looking at the total dose over the patient pathway, right from diagnostic through to follow-up, and how we as practitioners, I suppose, can look at the areas within that we can start to maybe focus more on dose optimization. And of course, because what we're trying to do is reproduce the target volume on a daily basis, as we all know. And when you take that, when you go on down through the legislation, when it's implemented, then when they go a bit further, it's based on the principles of justification and optimization. So they're key. And I think we still need to look at those two under radiation protection legislation in radiotherapy, but from a slightly different perspective. From our point of view, all individual medical exposures should be justified in advance. And when you're doing that, you want to look at the specific objectives of the exposure and also the characteristics of the individual involved. And for us, that's absolutely more critical. If you're looking at diagnostic, you might be looking at, well, how well is the patient able to stay still for a single exposure? For us, we're looking at the patient status from quite different perspective. And then we're looking at optimization, but that's based again on the magnitude of individual doses. And they must be consistent with the medical purpose of exposure. And I think if you take all of the different elements, it puts us into a completely different category than diagnostic imaging or nuclear medicine. And actually, nuclear medicine are having the same discussion at the minute, because with the increasing use of therapeutic applications, they also aren't really covered under this current legislation. So what I would put forward, and what we are a group of us writing a paper in ESTRA at the moment, is that we need to look at optimization based on the magnitude of individual doses. We need to look at how consistent that is with the medical purpose of the exposure. And then we need to look at the selection of the equipment that's available to us and how can we best use that to achieve our aim. And that brings us into the whole area of quality assurance and verification as well. And I suppose the fundamental difference, as I said, is diagnostic imaging is usually a single event. Okay, they might repeat images, or they might over a course do several images, but it still is a single point in time, where radiotherapy is a treatment process over a period. And I think that is a definition that, as radiation therapists, we need to keep stressing, that we are a therapeutic procedure and not a diagnostic procedure. So if we look then at justification, I don't think I want to update anything. If we look at optimization and justification, then how do we relate that then specifically to radiotherapy? Okay, so exposure of the target volumes have to be individually planned, okay? And this is coming from the EU legislation, and this is fine actually as far as it goes. It doesn't go far enough. Delivery has to be appropriately verified, and we have to take into account that doses to non-target volumes and tissues shall be as low as reasonably achievable and consistent with the intended radiotherapeutic purpose of the exposure. But again, it's very generic and doesn't really delve into what we do. So what we've been trying to look at in radiotherapy is, obviously we're trying to avoid any unnecessary radiation dose. And that probably doesn't come across in the legislation, that is part of our purpose. And it's quite different to deciding whether you'll take an X-ray or not, because we have imaging, we have treatment, we have planning. So we have a whole lot of steps where this needs to be considered. And the key thing is that we're treating cancer, which is a life-threatening condition. And this was really a very interesting thing, because I was on a Zoom yesterday about a particular EU project called Sinfonia, and they were talking about because they weren't radiotherapy people, about the fear patients had of inducing a second malignancy and whether that was preventing them from having radiation therapy as a treatment. And we were saying, well, that's actually not the case. I mean, we don't induce that many second malignancies. It's a very rare event. So that's not the concern of patients. But I think for me, it was an example of when people who don't understand radiotherapy try to write legislation for us. Because for us, the benefits usually outweigh the risks. And that's one of the first decisions that you have to make from a justification perspective. Does it actually outweigh the risk? And for me, it's what makes radiotherapy really totally different to diagnostic radiology. So if we look then at how we might implement or how we might consider justification and optimization in radiotherapy. So what we're doing, and it's maybe something that will become more common as we move to more individualized treatment and maybe as we become more conscious of things, is that we should be following the patient pathway from the beginning to the end. We tend to be a bit segmented, so one person is responsible for this part, somebody else for the next part. And it should start, therefore, at the decision to treat, right at the very beginning, in terms of the referral. And this is where justification becomes key, because the decision to treat should be made by a radiation oncologist. And I've visited lots of departments where that's actually not the case. You'll get surgeons or urologists who will decide that they'll do a certain procedure and then they'll refer for a bit of radiotherapy. Whereas this decision should be made at a multidisciplinary team meeting where the radiation oncologist is a full member and where the decision is not only based on will we have radiotherapy, but where in the pathway it should come. And that's a decision that can only be made by a radiation oncologist. You have a lot of discussion at the minute. And only because I know three young women with breast cancer who are all having completely different approaches. But one girl has had a reconstruction immediately following surgery, is now in the middle of very high dose chemotherapy, and then will have radiotherapy. And I mean, she's already afraid because other people are telling her that the prosthesis can react very badly to radiation. So in a way, that's an example of a lack of consideration at the very beginning at an MDT, because it should be based on full information available. You're looking at the timing, and then you're looking at the optimum prescription, however that is defined. So then when your radiation oncologist, when the decision to treat, to refer for radiotherapy has been agreed, then you come down to the optimization component, which is based then on the number of fractions you give. And again, that's very interesting in radiotherapy when you look at it globally, because it should be just quite simply evidence-based that this is the optimum treatment for this patient with this stage of disease. But very often you have issues like reimbursement criteria, where if a department is dependent on income for the number of fractions they deliver, it's very difficult then for them to move to the low fractions or the hyperfractionation or any of those kind of approaches. So that can be an influencing factor, which is reality, but probably is inappropriate. It might also be equipment and technique selection. If you don't have the optimum equipment available, if you can't implement the range of techniques for one reason or another, that's going to influence your decision on the treatment approach you take. And also, which is very key, is the patient status. How fit is the patient to undergo a specific treatment regime? So these are all the decisions that are made and should be made by the radiation oncologist at the MDT in order to justify radiotherapy as approach, but then also to begin to start to optimize the way it's delivered and the way it's prescribed. So this is what we're doing in this particular paper, is we're taking all of the elements of the patient pathway, and then we're also putting questions into a table. So if you're looking at referral to radiotherapy prior to the treatment decision, then have you looked at all of these factors? And can you say yes? And it's a very useful guide. If you're, say, organizing an MGT, then in advance you can look at all of these. You can say, have they got all of the right diagnostic investigations carried out? Have we got all the test results available? All of these kind of things. And then, is the use of radiotherapy in that circumstance for that patient evidence-based? And the other thing which maybe comes very much into the radiation therapist role is if you're having pre-planning images, for instance, or verification images, who is actually acquiring them? If you're in a department where there is no CT scanner, or maybe more commonly now an MR imager, then are you taking the images, or is somebody in a diagnostic department? And how is that managed? You know, are you having a radiation therapist go to the diagnostic department, or have you well-defined protocols that explain to them what they need to do and how they need to do it to make it an appropriate image for therapy planning rather than for diagnosis? So these are factors that we thought might be very useful for people just practically to go through these little checklists and see, yes, we've considered all that. So yes, our decision or our practice is going to be as good as we can make it. And then if we go further on down the pathway and we get as far as treatment preparation and simulation and planning, and obviously what we're trying to do at that point is to minimize the dose to the organs at risk. So we're looking at how tight a safety margin can we put in place to try to achieve that. And again, you come back here to the choice of equipment that's available to you that allows you to make that kind of decision, and then the technique that you can or can't implement. Because, you know, it's ideal to say, oh, well, this is evidence-based, this is perfect, if you can't actually do it. And then you have to do the best you can with what resources you have available. So obviously, say for pediatrics or in other circumstances, protons would be ideal. But if you haven't got protons, and also if you're not skilled in the use of protons, there are more and more issues coming up that need to be considered, but then you can't use them. So that's not the point. Now, with SBRT or IMRT, some of that comes down not only to the availability, but also to the educational background of the people who are going to be implementing it. And this is for me where radiation protection, as it's defined, is completely useless, because it doesn't doesn't let you introduce into your radiation protection, into your radiotherapy curriculum, things like radiobiology in detail as to what happens to normal tissue when you irradiate it. And that gives people a much better understanding of what happens when they treat patients, and therefore how careful they should be in adherence to margins or positioning, immobilization, or what have you. So we're minimizing the dose to the organs at risk. We're looking at the imaging modality we're going to use. And that's where I said earlier, where you can look at how, where, and by whom are the images acquired. And for the radiation therapist, that's within our realm to control that and make sure that that's done really well. Because what you're trying to do is make sure that your tumor site is optimized for planning. And that's going to avoid re-scanning when the patient comes to that point in time. And this is where optimization for the radiation therapist can be really important, because you can look at every step that you're involved in and make sure that your imaging is optimum for what you're going to use it for. Not optimum in a diagnostic sense, but why am I taking these images? What am I going to do with them? And how are they going to impact next stage down the line? Okay. And I think we will reach a point in time where we will have to start recording the dose that we give in these other settings. If for no other reason than to show that we are aware of them. I don't think it's the dose as such. It's more, what are we doing with the images and how are we recording them? Are we just taking them because we can, or do we absolutely optimize them? So I think we will reach a stage where all dose will have to be recorded in some way or another in patient notes. And we're doing that obviously to remove the need for rescanning or re-imaging. Okay. Yes, and that's the other thing. Are the professionals responsible familiar enough with the radiotherapy process and the subsequent application of the images? So that's what I say. We're the people who know that, so we should be involved in that particular process. So what does that mean? I mean, sorry, that's lapping about a bit on me. If you go to a diagnostic department, the MR couches, they're usually hollow. So we have to look at, well, do we put flat tabletops in? Are there lasers available in the imaging department? Also, who's going to position and immobilize the patient? Because the diagnostic radiographers won't understand what we're trying to do. And also, what are the scan parameters? Because they will have defined scan parameters on their CT unit, but they will be for diagnostic use. Whereas our scan parameters may be different because we might be looking at potential sites of spread, for instance. So these are the important kind of key factors to think about. And again, we have the same set of questions to ask yourself prior to that procedure so that you can begin to say, yeah, okay, we've done all the things that we can do to optimize the dose as far as we possibly can. And of course, then this is where we absolutely are key to the whole process, because if we don't do this properly, then people may as well stop prescribing, because we are the final stage. So we are ultimately responsible for what is delivered to the patient in the end of the day, because we're implementing the treatment plan. And when we look at that, then we have to take into account, say, the function and physical condition of the equipment, and including the accessory equipment, because accessory equipment degrades over time. So how do we monitor? How do we manage that? We see the patient every single day. So what is their status and how does that change over time? And are we monitoring that and are we thinking about that? And funnily enough, where that becomes really key is when we move to adaptive radiotherapy, and we'll all be directly involved in looking at the plan, looking at our equipment, evaluating our patient, and then deciding how we'll treat them that day. And when we come to that level of responsibility, that's when a good education program based on sound radiation protection background becomes key. And of course, quality control is very much in our realm at that point in time, because obviously absolute accuracy is required. I mean, we all know that you can have very serious consequences and long-term side effects, particularly with higher cure rates. It's really important that your patient long-term has the best quality of life you can give to them. And I mean, I think sometimes we don't think about how that is our direct responsibility, that we're the people who can really influence what a patient's quality of life is going to be by how we work. And it does mean careful monitoring of patients throughout treatment, and also appropriate use of imaging. We have to look at imaging because it's key and it's much more part of our practice. And it's very much the focus of the regulatory inspectors, the nuclear energy boards, all of these people. So what we need to look at is our appropriate use of imaging, not necessarily just the use of imaging. What's the purpose of it? What are we taking our image for? Is it going to be of direct clinical benefit? And if it is, what's the frequency? Do we need to do it every day? And in certain circumstances, absolutely we do, but not in all circumstances. And sometimes there's a lot of imaging just because you can, but if you haven't understood what the purpose of it is, then you're not really maybe doing it in an optimum way. And I do think even though it's really quite negligible in the wider context, I do think we do need to start in some way recording the dose we give. It's obviously not absolutely comparable to a treatment dose, but I think it's important that we're seen to be taking this level of care with what we do. And again, we have the same table of questions that will help you to actually review how optimal your treatment is, and looking at, as I say, is it necessary to image daily? What are you matching? Is it the most appropriate site? Is it the most appropriate type of imaging? And then with your immobilization devices, are they compromised due to excessive use? I saw in a department with very poor resources, they had come up with a really clever idea, and they had a rotation system for their masks, and also for their headrests and their accessory devices, where they rotated them every month through the department. So in effect, they compromised equally. It didn't stop them getting compromised, but accessory equipment is hugely expensive. So at least it gave a standard throughout the department. And I thought it was very clever. And then we often don't think about follow-up, because the patient is gone and they've moved on to the next stage. And sometimes that's very difficult for patients because they're very lost. They've lost what is their kind of key support system for maybe 5, 6 weeks, 2 months even. And they can be a bit lost. But then if they're not being followed up in the radiotherapy department, if they're being followed up by a surgeon, say, or by a GP, they need to be consider, well, what are we going to do? How are we going to assess the patient? Is routine imaging absolutely necessary? And sometimes patients like to have an X-ray or an image or a CT at that point in time, because it gives them a bit of reassurance. But it is often not necessary. And what you need to do is have some level of protocols for the people carrying out the follow-up, so they kind of know what they're looking for. And you can then kind of decide, well, do you need imaging or not? And also, they're still getting additional dose. So in some way or another, we should try to capture that. I think it becomes much more complicated because they've left our system, as it were. But it's something that we should consider going forward as well. And again, we have the same questions to ask before you start with follow-up. And as I say, these would be useful if you're developing protocols for the people who are following the patient up, because oftentimes a GP won't see so many cancer patients or patients post-radiotherapy. And sometimes it can be difficult to work out, well, is it a tumor recurrence? Is it a result of the radiation or the chemotherapy? Is it a side effect? How do you differentiate? So I think follow-up is a slightly neglected area. But anyway, I've moved on to the last one. And I just kind of feel it's really important that we now try to see if there's a way of addressing the legislators. There's no point keep talking to ourselves, because we really can't influence it. We can do our best to practice as well as we can. We can do our best to try to educate ourselves. But if the legislation is actually a controlling legislation, then we need to see how can we get the people who draw up that legislation to understand why it's necessary to consider radiotherapy in a different context to diagnostic imaging. And I suppose that's what we're struggling with at the moment. Where do we go with it? When we can, as I say, keep talking to ourselves, and we can write papers, but there's not much point publishing it in our own big journals, because again, it's only ourselves are going to be reading it. And so if anyone has any good suggestions, they'd be very welcome. Okay, thank you very much indeed.
Thank you, Mary. And so I mentioned we'll take questions in the Q&A rather than the chat, please. So I'm just going to have a look and see what we have here. Yeah, so we have First question here. Do you feel there are invisible patients that current radiation protection does not adequately protect?
Invisible patients. I'm not sure that radiation protection legislation protects our patients at all in radiotherapy, to be honest with you. I mean, I think on the ground we do the best we can, but the legislation doesn't enable us in radiotherapy to protect patients if you apply just the legislation.
Yeah, and I think you raised a lot of very important points there, and it struck me, I suppose, in relation to older patients that we, you know, in terms of justification and treating them the same as younger patients, it's just not appropriate. You know, for example, we have so many cases clinically where we see older patients and they come through for treatment, and we realize when they're on treatment, they can't, you know, maybe they have morbidities, they can't hold still for treatment. We need to increase our margins, and they're just, you know, they're completely different to what we see maybe in the patient notes. So I think that's a kind of a classic example, isn't it? So yeah, again, you know, feel free to use the Q&A if you have any additional questions. I've one for Mary. It just struck me when we were going through the presentation, and it kind of resonates with other aspects that we've been working on. You think we have like an identity crisis in radiotherapy where we're always merged with diagnostic, and we need to be more assertive and kind of, I suppose, asserting ourselves as a separate profession. Is that part of the problem, do you think? Or
it's the total problem. I mean, it's not even us as radiation therapists, it's radiotherapy as a discipline. And where I think estro is wonderful, but it really has got bogged down in day-to-day delivery, I suppose, where somewhere along the line, if you look at a lot of the EU projects, they're run by radiologists, they're very dynamic, they're in there first looking for the grants. And I mean, we fight and fight and fight and fight with them through all those EU projects that they don't represent radiotherapy. You get documents produced that are written by diagnostic people that throw in a bit of radiotherapy and think that's great. From the radiation therapist perspective, I have no issue with, everyone thinks I hate the FRS. I have no issue with them if they addressed radiotherapy. My problem is they still don't think that radiotherapy is any different to diagnostic. I mean, I was at a meeting where one of them said, well, you know, the diagnostic radiographers, they might get a bit bored, and wouldn't it be nice to do a bit of therapy for a while? And you say, well, no, not really, you know, but it dictates our education program. And I think that's what's a real pity, that level of identity that we don't have.
yeah, and there's another very good question here. Is there an issue that RTTs have become too protocol driven rather than thinking about why we're doing things? Are we just doing it because it's in the protocol? This is another bugbear of yours, of course, now.
It is, of course, yeah. And I agree with you. I mean, and I think it depends. I had a real issue with protocols. It was nothing to do with radiotherapy, but it was a radiation oncologist with a very ugly cancer. And he was being treated in the private hospital where he'd worked for 18 years. And a nurse came in with a clipboard every day and asked him his name and his address and his date of birth. And I just said to him one day, why don't you just tell her you're John Smith? Because she's not listening to you anyway. I mean, it's a meaningless exercise. And it was because she was protocol driven. And I just said, well, will she not give you the painkiller if you don't answer her in some way or another? And I think it's the same in radiotherapy. I mean, if we know something isn't right, then we don't do it just because somebody else has written it down. And it comes back to, well, are we educated enough to do our job? Does our education allow us to query? Because that's what we need to be doing. I mean, if you think of where we sit, you know, the prescription is made, the physicists do the equipment. We actually deliver the treatment in the end of the day. Nobody else does. And if we don't understand fully what's implied in that, then we should have enough education and knowledge to be able to go back to the physicist or the radiation oncologist and query something without being afraid to. Yeah. And we should also know enough to be able to write the protocols for our own practice and review them and change them as necessary.
Yeah, and I think that comes down to kind of professional autonomy, and that
Mm,
can differ, of course, in different regions, can't it? And having the confidence to do that. I know that, maybe as a junior radiation therapist, you might not always feel as confident to question these things
yeah,
and confront, a radiation oncologist about different things. Just thinking my own practice of, scanning requests that were not appropriate, and
yeah,
trying to tackle that then with the radiation oncologist, I suppose. And that can differ from one country to another in terms of professional
yeah,
autonomy and being able to question
yeah,
and being respected, I suppose, as
yeah,
a
absolutely.
professional,
Yeah.
and having a discussion about that.
And particularly if you're in a very hierarchical system where, you're the lowest on the ladder, as it were, it's extremely difficult. But I've seen it with junior radiation oncologists who were watching a senior colleague do something that was absolutely dreadful. And they didn't feel they could question it, even though they knew it was completely wrong. But it's also, there's that professional hierarchy, and how do we position ourselves appropriately? But if you haven't got the education to do it, that also is a real difficulty.
Hmm. And there's another very good point here from Laura. It's essential to be educated, but the legislation needs to be on our side to act when red flags are identified. So it should be kind of a significant enough barrier that we're practicing with it in mind, rather than, I saw something that we have at the moment where it doesn't
Yeah,
necessarily take radiotherapy into account, to kind of the nuances of what we do daily
yeah,
in practice,
yeah,
and having that kind of level of protection as well,
yeah,
for
yeah,
patients in particular.
yeah. Because I've been to HERCA meetings, and HERCA, I have to, I'm very bad at acronyms, heads of European Radiation Competency. I don't know, anyway, they're a regulatory body. And they were totally and absolutely obsessed with the dose from imaging in radiotherapy. And I said, what are you talking about? You're talking about a couple of, maximum a couple of gray, when you might be delivering 80 gray as a tumor dose. So, this is nonsense, but it's because the legislation, that was all they could do. That was where it was all about a single dose, a dose from treatment or imaging, without considering what that actually means.
Yeah,
There's another one, is there?
absolutely. There's another question here. How can we engage the staff in FMEA analysis for the radiotherapy workflow if the culture is not implemented yet?
Um, Well, I suppose you can just keep ploughing ahead. I mean, there's absolutely no doubt that a lot of radiation protection legislation has developed out of analysis of incidents and accidents, some of the really major ones. And I think if you can even start with small talks to your staff on how beneficial it is to look at your practice regularly, to look at all the steps involved, to look at what the issues can be that arise, and then also encouraging them to see that by doing this, they can take some level of control of altering things or improving things or suggesting where improvements could make. So by, I suppose, empowering them in the technical jargon, but empowering them to be really part of it and to actually contribute to making it better.
Yeah, and I suppose it's down to education, isn't it? And auditing your practice as well,
Yeah,
auditing,
yeah,
your imaging practice, and, knowing what your department is doing, I suppose, at a basic
yeah,
level, and
yeah.
trying to improve, kind of basic everyday practice as well.
And it does, for me, and I mean, all of you know where I'm coming from, but it always comes back to education. We're not really, now I can't talk for Ireland anymore, but globally, we're not educated sufficiently in radiotherapy to be true members of the radiotherapy team. Because of our education program, it restricts what we understand, what we know, how we can engage and discuss with others, how we can suggest improvements to our practice. We're very restricted if our education is not specific to radiotherapy, if our clinical practice then is influenced again by people who didn't have the benefit of education education in radiotherapy. And if you're always under a physicist and oncologist who know more. So yeah, I think education is key in the end of the day.
Yeah, and I think you had a very good point as well about survivorship care. It's becoming more kind of prominent in every in every system as well, and we're becoming more aware of survivorship issues.
Yeah.
And I suppose we need to be more cognizant of how we can improve quality of life over time. And it's just the basic everyday practice is really important in that as well.
And partly because we're not part of the follow-up, we don't see the patients. Unfortunately, we tend only to see patients who come back with metastasis. That we don't have that system of actually seeing patients afterwards, which I think is very good, in that you can see if they have problems, then you can look back and say, well, could I have prevented that? Could I have done something that would have made that less problematic for that patient?
Yeah, absolutely. And just being aware of it.
Yeah.
Okay, so I don't see any more questions coming in there. And just a reminder that the recording will be available on our website if you want to revisit it at a later stage or share it with your colleagues. So just to say thank you again to Mary for providing this month's CPD webinar. We're very grateful for your input and raising a lot of very important points, I suppose, for us as radiation therapy professionals, and a lot of things to ponder. And it's great to see that there's work ongoing in raising awareness at a European level as well. So thank you, Mary, for joining us today. And thank you all for joining online. And with that, I think we'll close the session.
Bye, everybody.
Thank you.